Hello, everyone. Welcome also on my part to this presentation of a study I did last year. The study has about a year on it now. And the English title we have set to Why Prevention Matters for the Future of Healthcare Funding. And I will present the main results of the study. Maybe I should also say that the study is available in Swedish from SNS, and I will say this in Swedish. It's the Studieförbundet för näringsliv och samhälle. It's abbreviated SNS, and you can find it on their webpage. So my name is Kristian Bolin. I'm a professor of health economics at University of Gothenburg, and I'm connected to MedEngine as a senior advisor in health economics. Why is lifestyle choices important, and what has it got to do with healthcare financing? Well, the reason is that it's important. The reason is that, as everybody knows, there's a demographic transition going on. So in the future, there will be increasingly the case that fewer and fewer people will have to support more and more elderly people. And you can also project from that the demand for healthcare will increase, both as absolute numbers and also as sort of divided by the number of people in the working force. So question is, can we do anything about this? And the report I've done, or the study I've done, take the perspective of prevention. What can we do about the expected increase in healthcare by sort of improving less than good health-related lifestyle choices? So the study focuses on arguably the four most important lifestyle choices or lifestyle-related states. There are more, but I choose to focus on smoking, risky alcohol use, physical inactivity, and also on obesity. Obesity is not a lifestyle choice per se, but it's obvious that it has something to do with your lifestyle choices. These four factors are also modifiable in the sense that it's possible to stop smoking, drink less alcohol, be more physically active, and lose weight. Problem is, and I will get back to this later on in the presentation, problem is, and this is the fundamental problem that I point at in the study, that we know very little about how we can implement long-lasting lifestyle changes. We know something about how we can do that in the short run, how we can get people to lose weight, stop smoking, be more physically active. But in order for that to have an impact on your health or your risks for disease, you need to maintain those lifestyle choices over a longer perspective. And there we do not really know how we can accomplish that. There are some lifestyle choices left out. It's been pointed out to me here that vaccinations isn't part of this. True, it isn't part of that. So the study design and its objectives, we can say that I've estimated the societal cost, or the total cost of society, linked to these aforementioned risk factors: smoking, alcohol use, physical inactivity, and obesity. So I calculated what are the costs to society over a 10-year period that can be attributed to these four risk factors. And then I've calculated the savings or the decrease in the societal costs when you sort of take on an hypothesis that, well, let's assume that instead of 35% being obese, let's assume that it's just 20. How much will the societal cost decrease? And the difference between those two calculations will be the effect of a prevention that lowers the prevalence of obesity from 25 to 20%. And if you do that simultaneously for all risk factors, you can get a measure of how much money or what is the value of the resources saved or not consumed due to less than good health-related behavior, if we can get people to be more physically active, less obese, drink less, don't smoke. So there are two parallel calculations done, and the difference between the two is the effect of a sort of thought-up prevention. I'm sort of asking the question, what if we had a prevention that could reduce the prevalence of all the risk factors by X%? So I've used registered data over the period 2011 to 2021. And when I say registered data, I do not mean individual level data. I mean statistics, really, that comes from individual level registered data. Mainly from the Swedish National Board of Health and Welfare. They have an online tool where you can go, when you sort of can enter and ask questions, and you can get comprehensive statistics. So I've used from the registers, observed healthcare utilization and mortality over the entire period of 2011 to 2021. And I've also collected prevalence of the four risk factors at 2011. And nothing much is happening, so just adjusted them over the years. So, and also, I'd like to say, relative risks are collected from the medical epidemiological literature, and those are highly reliable. I mean, there have been studies about that for decades, and even if future studies sort of will modify the risk somewhat, we are in sort of the correct ballpark here, I think, with the figures we've used. So if you then calculate over for each year 2011 to 2021, I mean, that's sort of elapsed years. We know what happened, and we know how many people smoked and were obese and stuff like that. So we can calculate what's the societal cost of all these four risk factors. And then we can do another calculation. Then let's assume that the risk factors, the prevalence of risk factors have been 10% lower. What would be the societal cost of the risk factors then? And like I said, the difference between the two calculations is the effect of a hypothetical prevention. Maybe I don't need to say very much about this, but we have used, I mean, epidemiological methods. We've calculated population attributable fractions, which are more or less the proportion of, for instance, healthcare utilization that can be attributable to the prevalence of the risk factors. And the thing to notice here is that the attributable fractions are for the joint prevalence of the risk factors. Many cost of illness studies you see in the literature will just have one risk factor, and that will if you do it like that, you will be at risk for sort of overstating the cost, since many diseases, illnesses that are related to health-related factors depend on more than one such factor. And if you don't take that into account in your calculations, you might end up with biased results. So, like I said, modeling the impact of prevention then is just calculating these parallel calculations for different prevalences of the risk factors. You have one baseline calculation where the prevalence is what we know it was. And you have another hypothetical prevalence where the difference between the prevalence is the effect of the prevention. And once you calculated the effect of the prevention, then if you know the cost of the prevention, it's possible to calculate a cost effectiveness measure. And we have done that, but before we get to that, let me just present. This is I hope you have access to the presentation in a own document, because it's a little bit hard to see here. It's the presentation of the attributable proportions for every disease included in the study, and we can see here that this liver disease, alcohol-induced liver disease, and of course that's entirely explained by the prevalence of risk alcohol use. Other things that are very high is lung cancer, and I mean it's been well known that most of the cases of lung cancer are caused by smoking, but not all. So that means that if everybody stopped smoking or have ever smoked, you will still see some cases of lung cancer, but it will be reduced. And this slide shows number of healthcare contacts, and we have primary care, we have specialized hospital-based care, and we have inpatient care. The things to notice here is that primary care, the lightly, in my eyes, green bars, are divided by 10. And I've done that in order to get measurements that are sort of in the same ballpark numerically. So here, for instance, in 2011, we have almost 2.5 million cases, primary care visits, that can be attributed to the prevalence of the risk factors. If you translate the costs in physical units, which was in the previous slide, to monetary units. Of course, I won't go into the details, but of course, you need to have some kind of unit cost measures. I mean, for instance, what did a visit in primary care cost in 2011, and so on, and for the other types too. And that's presented in the report, the details about that. This outcome is after having done that, transformed everything into monetary units. And what's depicted in this picture is a 2.5, a 5, and a 10% reduction in the prevalence of risk factors. What would that result in reduction of the total direct costs? So, for instance, here the black ones are for 10%, and so that means that if the prevalence of the risk factors decreased in 2011 by 10%, by 2020 or 21, you will have, I mean, this bar here will tell you how much. I mean, it's almost 0.6 billion a year you will save. And why is it increasing? Well, it's because the calculations assume that we changed the prevalence of the risk factors 2011, but that will affect the relative risks of disease for those previously having smoked, for instance, gradually. So the relative risk will not momentarily align with those who never smoke, but it just over time decrease. That's why we get this slightly increasing scenario. This is the similar or analog picture, but for productivity gains, which means that, well, less days people are spending being sick, and less people are dying and can keep on working until they should have retired anyway. I just want to say, why is this pattern here then? Well, that's actually an artifact from the fact that a fair share of the indirect costs here are temporary illness. People are getting retired before sort of the normal age of retirement due to illness. But in Sweden in 2015, 2016, the system was changed. So people, for instance, in 2019, who would have been granted an early retirement in 10 years before that, weren't granted that in 2019. So this pattern is partly an effect not only of the change in the prevalence of the risk factors, but also it sort of illustrates like I say, an artifact that reflects the institutional change. So one of the conclusions, or the first conclusion, is that lifestyle interventions, and this is described more in detail in the report. What I have assumed, I mean, the characteristics of the intervention that had the potential of reducing the prevalence of all risk factors by X% is, I mean, a thought up prevention that's implemented sort of population wide. And there are some small experiments done in Sweden, in some regions in the northern part of Sweden, where you called everybody in certain age cohorts to have sort of health guiding talks with the healthcare givers in that region. But we don't really, like I said in the beginning, we do not really know how we can implement a prevention that will in a durable way change people's lifestyle choices. So that's why I say more research is needed here. We don't really know, but the calculations in the report, I mean, highlights the potential of, I mean, the usefulness in terms of the gains that we can achieve by implementing such preventions. And like I also said, it's not only the structure of the prevention, it's also about how is that structure related to the sort of how sustainable the results are over time. Will people keep keeping away from the cigarettes, for instance? And I stated that here, uncertainty remains regarding the durability of effects, and that's probably the most well, let's say serious, because it's serious. serious lack of information that we have when we do calculations like this. I also like to say that I think, and this I take up this last point because it's come up several times when I've presented this work before, and that regards the fact that, well, the premises are like we need to first identify all people who are smoking, are obese, have a risky alcohol consumption, and do not engage in any physical activity. And how do we do that? That's a challenge. And once you have identified them, how can you reach them with a prevention? And there's also, I mean, political aspects of that. Some people will argue that, well, we shouldn't do that. We should leave people alone. I don't have it. I mean, I won't take that discussion, but I mean, conclude that potentially society as a whole can gain very much if we can, on the margin, change people's lifestyles, or some people's lifestyles. Thank you.